Thomas splints and Balkan beam traction are used for patients who have sustained femoral fractures. In some cases, they can be the definitive treatment, and patients can be managed in traction for a number of weeks. As such, the setup of the traction system, along with careful care and monitoring, is extremely important. This video series aims to cover the entire patient journey, preparing the bed, application of the Thomas splint, and the connection of the splint into the full traction system. Finally, we'll cover some hints and tips for caring for these patients. Section 1. Building the Balkan beam traction bed. Here is the kit list for building the Balkan beam traction bed. On notification from the on-call orthopaedic team that a patient is coming into the ward with a femoral fracture, requiring treatment in a Thomas splint and Balkan beam, nursing staff on the ward should aim to build the bed as quickly as possible. Time is of the essence, as getting the patient settled into the full traction setup before their nerve block wears off is critical. Building the traction bed is a two-person job, and the bed should never be built around a patient for risk of injury. Lower the bed down to its lowest height to help with reaching the higher areas. First, take the head and foot off the bed and insert the end pieces into the now available holes firmly. Attach one long bar along the length of the bed. Place the bar off-centre towards the side of the injury, i.e. to the right of the bed if it's a right-sided injury. In larger children, an alternative to what is shown here is to fit two long bars with two cross beams, creating a more sturdy construct. Next, build the end piece for weights to hang off. It looks like a small rectangle sticking out from the end of the bed. The next thing to attach is the four pulley brackets. Place one halfway along the bed and then another halfway between that pulley bracket and the foot end. You can move the bar in close to the end of the mattress, as it's unlikely to need to be all the way out in children. Finally, and most importantly, check everything is tight. Every opportunity to confirm this must be taken. Section 2. Applying the Thomas splint. Here is the kit list for applying a Thomas splint. Application of the Thomas splint should usually be done in the emergency department, as it is here that optimal analgesia can be given. In most situations, this will involve the use of an ultrasound-guided femoral nerve block. This is hugely effective, and making sure your patient is as comfortable as possible is the most important thing. The actual fitting of a Thomas splint is ideally done by 3 people, minimum 2. 1 to hold the leg, 1 to apply the splint, and a third, if available, to assist. Prepare the splint. It needs to be of appropriate size, child or adult. Make sure there's plenty of space around the upper thigh for the bars and adjust it to length. And leave around 20 to 30 centimeters of space at the bottom for knot tying. The D-rings come in different sizes and should be large enough to go around the thigh comfortably with space either side to avoid pressure issues, but not so large that it sticks out significantly or impedes the other leg or groin for personal care. Measure the uninjured thigh and add several centimeters for swelling. Some D-rings have an ID tag attached to them, and so when joining it onto the splint, make sure this ID tag is on the outside and not in the groin. The D-ring wants to be higher on the outside and lower in the groin, essentially following the groin crease. Next, fit the foam Velcro sling straps. Again, make sure the Velcro is not going to be against the skin. These come in 2 sizes, which we've demonstrated here, and you'll need different sizes and numbers depending on the size of your patient. Make sure the heel will be left free, and ideally a small gap under the knee too. If these Velcro sling straps are not available, then use Tubigrip stockinette as an alternative. Make sure you've put the Velcro padded D-ring cover on, keeping the Velcro edge away from skin. The final thing to have ready is the skin traction kit. These come in two sizes, child and adult, and so make sure you've chosen the right one for your patient. The child one is for smaller, younger children only, and in this video we've used the adult one. In children, the adhesive form of the skin traction kit should be used unless an allergy is known or suspected. You will need to cut this to size, so have scissors ready. There is a sharp bandage clip included in the package. Discard this and have tape ready instead. We're now ready to begin applying the Thomas splint. First, check your patient's neurovascular status and that they're comfortable enough. The skin traction only goes up as high as the fracture, you don't cross it. In this case, we've simulated the maximum height it would ever have to go, which would be for a proximal third femoral fracture, and this would be up to the subtrochanteric region. Trim the adhesive strips as required. One person should then apply a gentle traction by straight line pulling the leg at the ankle and then lifting, staying in position throughout the skin traction application. Make sure the standing and holding position is maintainable before commencing. Carefully coordinate applying the skin traction adhesive strips directly to the skin, as shown here, trying to avoid any creases. The foam pads should be nicely overlying the ankle malleoli. The bottom end should be square so that the line of pull is straight, and there should be around 5 centimeters of space below the sole of the foot. It can be helpful to put the rolled up bandage in the gap between the foot and the foam pads to maintain this space. In this simulation, we've applied the adhesive strips over our patient's shorts, but in reality, they'd always be directly on the skin. Wrap the bandage snugly around the patient's leg, but not so tightly that you'll impede circulation. Avoid compressing the knee if you're going above it. Secure this in place with tape. Place the splint under the leg, making sure it's appropriately positioned up into the groin. And this is your next opportunity to fine-tune sizing. There must be plenty of space at the bottom to tie knots. Tie the skin traction onto the splint. There is a variety of ways to do this, but the key point is to ensure there's an appropriate way to adjust the tension, often using either a metal lollipop stick or double-stacked and taped tongue depressors, as shown here. The splint is now applied. Close the D-ring cover, check neurovascular status and comfort again, and then proceed to check X-rays to confirm appropriate positioning of the fracture. Section 3. Attaching the Thomas splint to Balkan beam traction. Once the patient has arrived on the ward, connecting up their Thomas splint to the Balkan beam traction should happen as soon as possible, whatever time of day. This is so that the nerve block doesn't wear off, but also to reduce the risk of groin pressure sores if the splint is left unconnected. Connecting up is a two-person job, and usually this will be the orthopedic on-call doctor and someone to assist. Make sure the patient is comfortably transferred into the bed from the ED trolley and sat at the correct part of the bed, essentially making sure that they can sit up appropriately as the backrest of the bed lifts up. Now, adjust the traction bed to make it fit the patient. Align the long bar over the leg if using one single bar, as shown here, and then ensure your pulleys are at the level of the hip and halfway down the gap to the end of the system. Take a length of cord, better too long than too short, and tie it first into the groin loop. and then take it all the way around the 4 loops of the splint, finishing on the outside. Doing this as one single piece of cord, rather than 2 smaller pieces, one on either side, allows you to adjust the length more easily, and also allows the 2 sides to balance. Tie your knots carefully with multiple throws for safety. Clip in the splint cords and have an assistant holding this pulley over the leg. Attach a long piece of cord somewhere around 2 to 2.5 lengths of the bed to the orange large pulley ring. When constructing the pulley system, remember to go towards the head first. After this, the sequence is easy to remember. Go towards the head, back under the large pulley wheel, up again to the other high pulley, and then down to the pulley on the foot end bar. It's best to use the pulley closest to the midline on the foot bar for this cord. Again, check your knots and warn the patient that you're about to lift their leg off the bed gently. Once you're happy that your system is secure, you can add your weights. You want enough weight to simply suspend the leg off the bed a few centimeters. Take a separate, shorter piece of cord, tie it to the end of the splint, and place it through the final available pulley, attaching a similar amount of weight. Ideally, have the weights at different heights so they don't bash together, making noise whenever the patient moves. You can then adjust the pulleys at the end if required to position the patient's leg in 10 to 15 degrees of abduction, as this makes toileting and personal care easier. Check neurovascular status and comfort, and tilt the whole bed slightly head down, so that the patient's body weight provides counter-traction and they don't get pulled down the bed. Protect parents and caring staff from the bed. Wrap some towels around the protruding end bar as required, otherwise they can be quite painful if you catch yourself on them. Section 4. Nursing a patient in a Thomas splint and Balkan beam traction. Finally, a few pointers when it comes to looking after a patient in traction. Analgesic requirements can be quite high. They've broken a large bone. Regular diazepam, on top of the standard analgesic regimen, is useful to counteract muscle spasms that occur quite frequently when the nerve block wears off. As can be imagined, going to the toilet is a challenge, and patients can often become quite constipated as a result of both the painkillers and simply their positioning and confinement to the bed. Laxatives are a must from the day of admission. Regular, at least daily pressure area checks should be carried out thoroughly. Common problem sites are the heel, the groin, around the splint itself in larger legs, and the toes from the traction cord. Barrier dressings or padding can be required to protect the patient from their splint. With time, the patients can become quite mobile in the bed within this traction setup, and so it's not uncommon for the whole system to become unravelled or tangled. If there's any concerns, even if that concern is simply that something just doesn't look quite right, contact the on-call orthopaedic team. Balkan beam traction will naturally try to pull the patient down the bed, and so they may need pulling up the bed every so often, even if you have tipped the bed slightly head down. The easiest way to do this is to have someone either support the weights as you do it, or alternatively, place the weights on the bed temporarily. Then you can carry out any movements, personal care or care interventions, for example x-rays, and then gently resuspend the leg once that's done. The sole purpose of the weights is to pull the splint out of the groin and protect the patient from pressure sores. The leg can come down to the bed if required every so often to make care interventions easier. The orthopaedic on-call team should check the traction at least daily, but simply, if there are any concerns, don't hesitate to contact them.